We're going to get started. So what we've done here, this is like I said, Russian roulette. You kind of run in here, you see what you got. Obviously, in the real world, we would know our patient's anatomy. We would have advanced imaging with an MRI, really understand, the procedural limitations or any issues here before jumping in. And I'm going to go on to talk about the implantation. So really important that prior to the implant, you always have the patients see what it's like to live with an IPG. So one of the things you can ask patients to do is put a dental floss box in an area. A number of implanters will put the IPG below the belt line in the buttock. Others will go above the belt line in the flank. So you want patients to really experience that, because what you'd hate to do is have a therapy that works really well, but then they hate where the battery is because they sleep on that side, or they just don't like where it is because they wear a tool belt. I had a patient where they were like, oh yeah, no problem. They hadn't worked for 2 years as a police officer, so they were like, no problem, just put it in my right buttock. I went ahead and did that, and then 6 months later, he came back and he's like, you know what, I'm back to work. I've got my gun belt, and it's rubbing the IPG, and so that's a problem. So I actually had to move it for him, but he didn't actually think he was going to go back to work. That's why he wasn't even thinking that far ahead, but because he was doing so well with the stimulation, these are the things we had to do. So if you can prevent those kind of issues, obviously, do so in advance. All right, so hey, how are you?
Good, how are you doing?
Good, what was your name?
Matt Schonard.
All right, oh my God, are you related to the?
Yes,
oh
yeah.
my goodness.
I think they sent me in here baptism by fire.
So, Ramo, I asked for a fellow, but I sent you a future fellow. He's not in his fellowship.
Yeah.
Awesome. So great school. Thanks for being here.
Oh, yeah.
So we're going to jump into S1 DRG. So again, we're looking at this anatomy, questionable transitional anatomy, if you guys can appreciate that here, whether this is an L6. I'm not going to go ahead and count everything, because what we're doing here is really just trying to give you guys an idea of how to manage patients who potentially have feet pain, whether this is from diabetes, from chemotherapy, from idiopathic reasons. So S1 DRG stimulation has been a really nice way of treating or managing patients with plantar foot pain. So if we can bring the machine caudal towards the feet. Yep, towards the feet here. And so I just want to zero in a little bit, and we'll take a shot there. I'll take the pedal if you don't mind.
Want the foot pedal?
Yes, please. So there are these lines that are sweeping from, we'll call it the L5, but again, guys, it's probably a transitional segment, and you can probably appreciate why. Perfect, thank you. So there are these lines sweeping along the pedicle, and I don't know if Doug can point that out on the screen, but these are called Charlie's lines, and these lines are basically giving you an outline of how the nerves run down the thecal sac and then out of the sacral foramina. So these are going to be guides to help us understand which orientation you want the lead to be placed. And then what I do is I'll have Steve go to a lateral view to give us an understanding of what the sacrum looks like. So there's actually a book from years ago looking at sacral anatomy, and one of the things the authors appreciate or describe is that sacral anatomy is extremely variable from human to human. Unlike the lumbar, thoracic, and even the cervical spine, there's a lot more homogeneity in those parts of the spine. The sacrum has all sorts of different curvatures. Some segments are fused, some are not. Further towards the feet here, Steve, there was another procedure here you can see. And then raise the C-arm up, and a shot there. Okay, perfect. So I'm going to just take this 2E needle and just give me a shot there. Okay, and I'm going to just come here. Perfect. Perfect. I'm a little low there. Shot there. Yeah, I'm a little low. There we go. There we go. All right, stop there. So what I'm doing here is I'm basically aligning that S1-2 rudimentary disc, because that's basically the angle of the neuroforamen in the sacrum. So I'm just going to actually, this is a cadaver, so I can do this. Don't do this on your real patient here. But I'm going to give Steve a guide to his cranial caudal tilt based on this angle here. So let's just take a picture there. Perfect. So you get a rough idea. So now, Steve, come back over, and I want your cranial caudal tilt to match the needle so the needle becomes coaxial. You probably won't be able to see the needle because I'll just tell you because it's a bit out. I put it off more laterally so not to interfere with some of the other procedures we're doing. So more cranial tilt on the eye or caudal on the source. Perfect. Okay, perfect. And then just center the sacrum if you don't mind. So periscope towards you to center the sacrum. Perfect, and shot there. Okay, and just, back in a little bit. Perfect. Okay, so I'm gonna start on the right side. We'll just say this patient has right foot pain. Perfect, that was not the floral picture. It's just storing here rather than, can you take off the store here?
So step on the left side.
I am.
Oh.
So there is an issue with the pedal. So there's an issue with the pedal here, Steve. I'm stepping on the left side. I'm not getting.
Okay, let me do it.
Okay. Perfect. So we're following, I'm just going to go a little medial to that because right now I'm a little lateral to Charlie's line. So perfect. I'm going to put a shot there. So I'm right over that frame in here. If you guys can appreciate that. And then what I'll do is if there's any side of the foramen to consider, it's being medial and rostral because the angulation of that needle is going to be basically towards the right foot and towards the left shoulder. That's the orientation you're going to end up taking. And then what I do here is I make a less than 1 centimeter incision that's following Longer's lines, so it's going horizontally because that's exactly all you need. And then I'll take my 14 gauge Tui, which I've already put over here. And then I'm just going to follow down basically coaxial to the sacrum. Oh yeah, go ahead, Steve. Sorry, I feel like used to using the pedal. So I'm a little bit lateral here. And so I'm just feeling around to get to that foramen. And we'll see what we get here.
One of the most common errors is you go right down on top and don't have the II appropriately angled. Because the sacrum is, if the patient is laying down here, is very flipped dorsally. So that was the whole purpose of having that needle, so you can orient the II cranial.
We'll go lateral here. So I just felt a loss here. We'll take a look, making sure we're at S1, because sometimes that S1, S2, looks like an overlap, depending on the curvature of the sacrum. But here we'll be able to see. But that was a really nice loss that I felt. So basically what was happening is I was just walking along here. That's perfect. So that is at the S1 level. I love that. So I'm generally walking on the sacrum, making sure I'm following that Charlie's line, and then eventually you're going to get that fall. One of the confounding issues in sacral cases, whether you're doing radiofrequency ablation or sacral DRG, is that bowel gas will interfere with what you're thinking are the sacral nerve flow. There are some people out there who request a bowel prep to help reduce that issue. I like my patients, so I don't do that to them. So that's why I've just become more adept at really getting to the S1 foramen, just as you saw here, really making sure I do that lateral view to begin with. Sure, it seems like an extra step, but it can save you a lot of time and a lot of trauma feeling around with a needle. So this is great. So what I don't know if which cameras have a view, but what I'm going to do here is I'm going to turn the bevel towards the right foot because that's the orientation I want my lead to follow. I like where my needle's at. It's a little deeper than where it needs to be, but I actually don't mind that. What you really don't want to do is just be anterior to the sacral plate with your needle. Okay for your lead to go out there because it's relatively soft. So what I'm doing here is just dropping in the sheath. And I want you to appreciate that the injection port and the black line of the bevel are lined up together, shot there. And this is definitely a procedure where it's advantageous to have a pedal rather than asking Steve, but we'll deal with what we deal with. That's totally fine. So what we generally want is one lead to be out nowadays. Historically, what we did is we advanced 2 contacts anterior to the anterior sacral plate. But what we've learned, Dr. Falowski did some of this work, is where are the sacral DRG? Where do we really want the stimulation? And it's really in the cannula itself. So within the sacrum on a lateral fluoroscopic view is really ideal. So right now I'm a little bit more advanced, and I like this with one contact out. And I want you to appreciate a couple things here. At the very tip, there's this thin line that almost looks like a tiny, tiny ring. Ignore those two other rings, that's from another procedure, but just talking about that sheath, there's a really thin line tip. That's the tip of the sheath, okay? And then there are those 4 dots. Those are the 4 contacts of the lead. So fluoroscopically, what I'm looking at is a lead that's slightly retracted from the tip of the sheath. Do you guys all see that? Okay, so if I just pull my sheath back while leaving the lead where it's at, we'll take a shot there, Steve. Okay, now you see 2 electrodes, that thin line, and then 2 more electrodes. What this tells me fluoroscopically is that my lead is now out of the sheath. Does that make sense? So it's really important to really train your eyes to understand where's the sheath, where are the electrodes, because that's really important. If your lead is too retracted, your sheath is now going like an elephant's trunk or an anteater, and trying to go through that epidural fat is really challenging. It's basically not aerodynamic and it's blunt, and you won't really be able to progress. So what you really want to see to make sure that your lead and sheath are married appropriately is that distal contact, number 1, is overlapping that sheath tip. So that would be the ideal situation. Now, for this situation, we don't have to do this because what I'm going to already do here, as you can see in this picture, is my needle is retracted to the epidural space, which is that radiolucent line. You can follow up to L5 and L4, that posterior aspect of the sacrum. It's still within the sacrum, my needle. My lead is now out. It's a little bit more out than I want, but that's okay. I'll be able to pull that back. And then my sheath is now at the anterior sacral plate, and now I'm going to retract the sheath. So we'll do pulsed, Steve, if you don't mind, and live. And perfect. And you're going to see me retract that sheath into the needle. Stop there. Stop there, Steve. Okay, great. So now I'm going to rotate, if you can see outside of the body, my whole complex, the sheath and needle, towards the left shoulder, and we'll take a shot there. So you can appreciate here, now that the lead has kind of popped up, the needle bevel is now looking upwards. And so now what I'm going to do is, again, I wish I had pedaled, but that's okay. So Steve, go ahead and start. And I'm going to see, go ahead and start shooting. I'm going to see if my lead will advance up the track. So I'm going to retract my needle a little bit. And not quite. Keep going here, Steve. Hopefully that's under pulse and not pure continuous. Great. So I'm struggling there. This is normal stuff. We'll stop there. I'm going to pull back my sheath a little bit more. Shot there. Okay. So now what I'm going to do is I'm saying, all right, what's happening is I'm continuing to go down the cannula rather than up the sacral epidural space. So watch what I'm doing outside of the body. I'm going to turn my needle a little bit more medial because, again, that epidural space for the S1 nerve root goes from left shoulder to right foot. So I'm turning this a little bit more medial, and now I'm taking the needle and I'm having it stand up more upright. So let's take a shot there. Just a quick shot. Perfect. And then let's do live again, and we'll see if this does it. Okay. And I'm going to try this just to advance lead only with stylet further back. Keep going there, Steve. So you can see it's starting to head up, which is okay. There we go. Did you guys see that? It popped the lead back. That's perfect. You can stop there. So this is great. So the 2 techniques I'm considering in this situation is, number 1, do I try to drive my sheath up there? Or do I just use the lead to do the work? And in this situation, the lead did the work. So I'm actually ecstatic with that because now I have that rostral turn, which I like to see. And now what I can do is turn everything back towards that right foot. Take a shot there, okay? And then go ahead, Steve, just go live again on pulse. And I'm going to just slowly advance more loop lead. I love that. She came back a little bit, so I'm going to advance that a little bit further. Perfect. Stop there. So now I've created a rostral loop and a caudal loop. And now I'm going to do the same thing again. So I'm going to turn everything towards the head. Take a shot there, Steve. Perfect. See everything's facing up, and now live pulse. So you're going to see that rostral, yep, there it goes. And I don't know how good the screen is for you guys in the audience, but hopefully you're appreciating what I've done here are 2, stop there, 2 rostral loops, 1 caudal loop. That's an M or that's a W. So this is perfect. I have 3 contacts within the cannula of this S1 on the right, one contact out, and the importance of that one contact out is there are ligaments on the anterior sacral plate, so it's going to hold that lead. So when the patient starts dancing, because they're so happy, you don't want that lead to jump out. And now what we'll do is we'll take a look at an AP, and Steve's going to show us that orientation following Charlie's lines, which again goes from left shoulder to right foot. All right, so do you guys appreciate that? That lead is following that Charlie's line, coming from the S1 pedicle down, and you see the loops going back and forth. So this is really ideal placement. I'm super happy with that. So this is where we would go on to the implantation, but I do want to show you one other thing, because a number of people who are watching on YouTube will say, well, sometimes I have a lot of difficulty creating those loops in the epidural space. So Steve, I'm going to have you come back to a lateral. And I want to show you a technique that I use, that I actually had as a poster at the International Neuromodulation Society in 2017, and that's the use of an extrasacral loop. And this is something that if you're in a tough situation where, for example, as you get more caudal in the sacrum, you get to S2 and you go off-label to S3 and S4, the epidural space gets smaller and smaller and smaller. So it's really hard to maneuver in those locations. So what I will do is something called an extrasacral loop. So Steve appropriately raised up the C-arm. If you can take another shot there. Okay, so you can generally see the posterior border of the sacrum. It's not ideal. He's going to optimize some of the, he's going to optimize the picture, hopefully. So in this situation, what I'm going to do is take out the needle. So you can take off the collimation there, Steve, because I'm going to work. Yeah, because you're blocking my view from where I'm going. So I'm going to bring the needle back a little bit further, take a shot there. Okay, so you see now I'm exiting the epidural space with the sheath. I'm going to go back just a little bit further, shot there. Okay, and what's happening here is now I'm outside and I'm riding on that posterior plate of the sacrum. So what I'm going to do here is lean the needle up, shot there, and I'm just going to see if I can advance. There you go. I don't know why it skipped there, but see what I'm doing is I'm riding the outside of the sacral plate with my sheath, stop there, and I'm going to now unscrew and retract lead. Okay, shot there. You can see my sheath coming back into the needle. And generally what's happening, and we'll stop there, what's happening is the needle doesn't want to hold because it's not in the foramen of S1. It's wanting to wobble. So notice what I'm doing here. See how my left pinky is holding the needle? So I have super strong pinkies now because of this technique, which I never had before. So the first time I was doing this, like my pinkies were failing, and I was like, I really need strong pinkies. Now my pinkies are really strong. So this is how you have to hold it. Basically, you're doing all sorts of things manually in order to get this extrasacral loop, and you can, again, do the same thing coming caudal. And what you'll notice here, as I rotate these together, now I'll lean the needle away from me, shot there. Okay, and now you can see how it's looking downwards. And if I can create more loop, I will. But otherwise, I'll just feed lead, shot there. And it's probably just going to create more of that loop. And anytime you put a loop in, you're creating, again, a spring or resistance to energy that can pull it out. And then I'm just going to take all this out, because right now the needle is out. It's a beautiful thing. And so we are fully out. Take a shot there. Great. So that's an extrasacral loop in case you encounter a situation where you cannot make those loops in the sacral cannula.
Good tip there, Ramo. That is incredibly hard to do. He made it look very easy, but this is not easy. And as he mentioned, the farther down you go, the more difficult this becomes because the epidural space, it becomes very narrow. So doing epidural loops at S3 is really tough. So burn that into your conscience. That's a very good tip. There's a plane that goes over the dorsal part of the sacrum that you can access, and you can do this. This is, God made that plane so you can do an extrasacral loop for your DRG patients. That's why it exists.
Perfect. And then the last bit of this, I wanted to talk about implantation. We don't have much time, so I'll just kind of run through this really quickly. But basically, understand your IPGs, whatever you're working with. and really understand the length. So for these kind of IPGs, these eggs, what I like to do is make an incision that's the length of the interface between the metal and the plastic or silicon, the header, if you will. That's about 4 centimeters with this particular system. So I make a 4 centimeter incision wherever the patient prefers to have it, whether in the buttock or above in the flank. I follow Longer's lines. You have to get through Scarpa's fascia, obviously, to make sure you get to the right depth, because you don't want this to be too superficial. If it's a rechargeable system, you generally get to a 2 centimeter depth because you need to interface with the recharging paddle. If it's a primary cell or non-rechargeable, you can go as far as 4 centimeters with most of the commercial systems out there. And so I like the primary cell because you can put it deeper. Patients don't notice it as much. And once we do that, create that pocket, there's a template which you'll get, which is the fake IPG. It's in the same shape. You put that in, you feel it out, finger dissector, METs, electrocautery for bleeders. And then once you have that created, you will tunnel with a tunneling tool, which we're just going to get here, and has a straw. And I just want to show you just some tips and tricks regarding this. It is very sharp, so don't poke yourself. But what you'll do is, what I always do is I'll create a little curve to it, a little English, and that helps me steer it a little bit. You don't want it to be super acute like this, because then it's going to, like, when you turn, it's going to really create some issues in the patient's body. So you want just a slight bit of English. Just hold it with the tip sticking out so you don't cut yourself and then bend up. And then what you'll do is you'll enter, and you need to get in the adipose layer. If you are meeting too much resistance, you're likely either too close to the skin or in the dermis, or you are in the muscle. And you don't want to be in either. If you're in muscle, you're going to create bleeding and a lot of discomfort. If you're in the dermis, really uncomfortable. So make sure you get in the adipose level layer. So you can just kind of feel here. And so I don't know the habitus, but you get a feel here just by wiggling. And then it just goes really slick. It's just really smooth there. It shouldn't be something where you have to put a lot of effort. You shouldn't see the tissue moving too much. And then you take that to the IPG pocket, wipe down the leads as you take out the straw, and then connect to the IPG. So for the purposes of time, I won't go through all that because I think we need to move on to the next.
Sounds great, Rama. Thanks for that. We'll open it up to any questions, comments. Yes, back.
Any recommendations for seroma prevention?
So did you hear that, Rama? Any recommendations for seroma prevention?
Great question. So there are some things you can do, just ensuring that you have appropriate, I know you're talking about seroma rather than hematoma, but just make sure you do have adequate hemostasis, making sure your closure is done in layers. You can apply pressure, whether that's an abdominal binder to the area or ensure that the patient lays on the area where the IPG is, because generally the seromas are an issue around the IPG rather than the anchor site. But quite frankly, you can do all those things and seromas happen. So those are the best tips I have. There's a discussion of whether pocket powder vancomycin is harmful or helpful in that situation. I don't think we have the perfect answer for that because, again, I think seromas happen in certain individuals. I've had patients tell me I'm prone to seromas from other surgeries, and lo and behold, they have a seroma from a surgery I've performed. So great question, but I do think there are patient influences on that we can't necessarily mitigate.
If you find yourself worried about seromas with powdered vancomycin, you can always switch to powdered ANSEF. It's another option for you. And this is controversial. I mean, I use powdered vancomycin in anything with metal in it. I think orthopedic surgeons use it only to excess. So, I mean, and there's nothing wrong with that. We don't see the seromas flourishing since the advent of intra-wound vancomycin. And remember that seroma, you go hematoma or seroma lymphocele. That's how it modifies. So if you have a bleed, it will modify itself to a seroma, then to a lymphocele just naturally over the course of time. Okay.